Routine breast imaging projections. Routine projections. Supplementar Y projection. Other modified positions. Imaging implants. 1. Craniocaudal. The CC projection best demonstrates the anterior, central, medial, and posteromedial portions of the breast, but is poor at visualizing the lateral breast tissue. Key points of the CC projection. First, position the detector at the level of the raised inframammary crease. The breast must be elevated before positioning the detector. Second, turn the patient's head away from the side being examined. Next, position the patient's feet apart with weight equally distributed. The ipsilateral arm is positioned by patient's side, while the contralateral arm is raised and the patient can hold the machine for support. Optimal compression is achieved if the patient is relaxed. To aid relaxation of the shoulder, place your hand on the ipsilateral shoulder and gently push down. Lastly, expose on suspended respiration, but try to avoid telling the patient to take a deep breath before the exposure. 2. Medial lateral oblique. The Malot projection demonstrates the extreme posterior and upper outer quadrant, but there is distortion of the anterior, central, and medial breast tissue. Key points of the Malot projection. First, the pectoral muscle should be wide superiorly with a convex anterior border and should extend to or below the level of the penielle. Second, the inframammary fold should be open. Next, dense areas off breast should be a dequatellopedidrid. There should be no drooping of the anterior breast and distortion of the architectural structures. Lastly, abdominal tissue should not overlap the breast tissue. Supplementary projections become useful when the standard projections are inadequate. This can be used to image a patient when medical or surgical history or body build makes the standard projections difficult to obtain. This provides more details of suspicious lesion or microcalcifications. This includes 90-degree medial lateral, 90-degree lateromedial, lateromedial oblique, tangential projection, exaggerated craniocaudolateral or medial, caudocranial or from below, cleavage or valley view, axillary tail, superinferior oblique, 90-degree medial lateral. This is a 90-degree lateral projection of the breast with the X-ray beam passing medial to lateral. 90-degree lateromedial. This is a 90-degree lateral projection of the breast with the X-ray beam passing lateral to medial. Lateromedial oblique. This is a true reverse of the Malot projection with the X-ray beam directed infralateral to supromedial. Tangential projection. This provides a profile projection of the area of interest, avoiding superimposition on other breast tissue. The X-ray beam skims the skin surface of interest. Exaggerated craniocaudolateral or medial. This is a CC projection of the posterior or medial breast tissue. The X-ray is directed superior to inferior with the patient positioned first for the CC, then turned laterally or medially. Caudocranial or from elbow. This is a reverse of the CC projections, with the X-ray beam traveling inferior to superior. The tube is rotated 180 degrees with detector to the top. Cleavage or valley view. This projection visualizes the deep medial breast tissue with the X-ray beam directed superior to inferior. Axillary tail. This is an oblique projection of the tail of the breast that is customized, with the angle depending on the patient's body habitus and/or radiologist request. The beam passes supromedial to infralateral, perpendicular to the angle of the axillary tail. Superinferior oblique. This is an oblique projection with the X-ray beam directed supralateral to inframedial. Other modified positions: rolled medial, rolled lateral, rolled inferior and rolled superior. Magnification, spot compression, rolled medial. After positioning the patient for the CC, the superior portion of the breast is rolled medially and the inferior lower portion is rolled laterally. Rolled lateral. After positioning the patient for the CC, the superior portion of the breast is rolled laterally and the inferior lower portion is rolled medially. Rolled inferior and rolled superior. These are lateral positions used to roll superimposition. The breast surface away from the detector is then rolled superiorly and inferiorly. RS. After positioning the patient for the ML, the medial portion of the breast is rolled superiorly and the lateral portion of the breast is rolled inferiorly. RE. After positioning the patient for the ML lateral, the medial portion of the breast is rolled inferiorly and the lateral portion of the breast is rolled superiorly. Magnification. Magnification images the breast with an increastoid, which results in magnification of the part. A small focal spot must be used with magnification to improve their resolution and sharpness to compensate for the large oid. However, the large oid acts as a Nair gap in reducing the amount of scattered radiation reaching the detector. A grid is therefore not necessary. Spot compression. With spot compression, more compression is applied to a localized area of interest using a small compression paddle. Spot compression can be performed in any projections or with or without magnification. It is not recommended for imaging of lesions directly behind the nipple. The small compression paddle will push or displace the lesion posteriorly. Imaging implants. The standard series of projections for a patient with an implant is the routine CC and Malot projections with limited compression, Plusklint projections, which are often called implant displaced ID projections. Most implants can be displaced by using the ID projections. The implant-in-place imaging refers to the standard projection taken to demonstrate the posterior breast tissue surrounding the margins of the implant. Compression is used for immobilization only. Vigorous compression should not be applied to the implant. The implant displace technique requires pulling the natural breast tissue forward while simultaneously pushing the implant back toward the chest wall. Maximum compression is therefore applied only to the breast tissue anterior to the implant. ID technique will work on all implants regardless of whether the implant is placed in front of the pectoral muscle subglandular or retromammary implants or behind the pectoral muscle subpectoral implants, as long as the implant is not encapsulated. 1. Before beginning positioning, the mammographer must locate the extent of the implant by feeling for the edges how far it extends. 2. Next, have the patient stand in position for a routine CC or Malot. 3. The patient then steps back, slightly away from the detector. 4. The mammographer locates the anterior edge of the implant and places the detector anterior to the edge of the implant. 5. The mammographer can use thumb and fingers to grasp the breast anterior to the implant and pull breast tissue forward. 6. Compression begins while holding and pulling the breast tissue forward. 7. The edge of the detector and the compression plate will help keep the implant posterior to the breast tissue and displaced from field of view. 8. The breast free of implant is compressed normally. 9. If there is sufficient breast tissue to cover the detector, automatic exposure control can be used. However, if enough breast tissue does not cover the detector, manual technique must be used.